Hi, everyone, and welcome for one of our last discussions of the day. This one is Case Discussions, RAAM Challenges and Opportunities. And welcome, Dr. Jennifer Wyman. Thank you so much for joining us for this presentation today. So Dr. Wyman is an assistant professor in the Department of Family and Community Medicine at the University of Toronto, associate medical director of the Substance Use Service at Women's College Hospital in Toronto, and the Medify program's medical educator. As a physician working in primary care and addictions in community and academic settings, her interest is in improving care pathways for people with substance use disorders through education, resource development, and advocacy across the healthcare sectors. So I know there's lots of people excited for this talk, so I'll let you take it away so we have all the time.
Thanks so much, Katie. It's a little bit daunting to be speaking in front of this group of colleagues who I feel have so much expertise. I guess my caveat will be I'm presenting cases for prompting thought and discussion. I've overpacked it, so I apologize about that as well. Many of these cases have a COVID lens, even though they're not COVID specific. And I guess the other thing I'll say is that they're really sort of focused on the outpatient clinical setting rather than emergency department and inpatient. So there may be lots of differences in terms of how you would manage some of these cases in different settings, but that's the lens I've chosen for this. Again, recognizing that RAAMs come in so many different shapes and sizes. Some of you are following patients longer term. Some are trying to do brief interventions. So briefly, I have to announce my disclosures. So I receive an honorarium or salary now from Medify as a medical educator. I received an honorarium from the Ministry of Health and Long-Term Care to develop the Opioids Clinical Primer, which is an online set of courses around issues around managing opioids, both opioid use disorder and chronic pain. And I was involved as the clinical lead for the Center for Effective Practice tool on opioid use disorder. And I've spoken for Toronto Public Health and also for the OCFP. So hopefully we'll be able to use these cases to think a little bit about developing benzodiazepine taper plans, look at some different ways of thinking about opioid agonist therapy. Perhaps maybe they're not different for all of you. And hopefully we'll make it to talking about alcohol withdrawal. I put benzodiazepines first. I just told Katie because they're my least favorite, and I feel like they always get put at the end of the talk and not addressed. So in an effort to make sure that we actually include them and recalling that there's something that comes up often on the listserv, I chose to put them first. And I did try to think about topics that have come up on the listserv and try to make sure that we've addressed those a little bit as well. So our first questions really are just about who's here, just so I know who I'm speaking with. So if you could let me know which settings you work in, and you can select all that apply. Looking at the names, I have some ideas, but hopefully this will pop up quickly. Maybe this means we have more people in the session and responding than I anticipated, and not just that it's a technical glitch. Because if it's technology, I'd rather move on to actually talking about the content. Thanks, Natalie. So about 30% of those responding, which is not everybody who's on here, are working in a RAAM clinic. And I can't see the rest of those. Oh, there we go. So lots of overlap, I guess, in terms of inpatient and primary care in particular. Great. The next question has to do with what your professional, I guess, sort of identification is, or what designation maybe describes your role? I guess that's my chance to talk about the fact that I'm really speaking in this session specifically about pharmacotherapy. And that's in no way intended to minimize all of the other things that are part of this therapeutic process, or the roles of people who are not prescribing. I apologize for missing that category. Licensed practical nurse, thanks. Okay, great. And then the last one, just a question about which substance use issues you're facing primarily. And again, please choose as many as apply to you. But most often, that should be one or maybe two. We all see all of them at times. And if you can only choose one, choose one. Let's move on. Pick the one that's of most interest, and that will help me think about, again, who's in the audience and what maybe want to focus on next conference when we're diving deep. Okay. All right. So since alcohol was the third on my list, we'll try to really make sure that we get there and move our way through. So let's talk about Dorothy. Dorothy was a Monday morning presenting to RAAM. No, she's a 50-year-old woman presenting to RAAM on a Monday morning. It seemed at first like she was just sort of stuck between a psychiatrist and family doctor. Her psychiatrist, who was ill, was no longer able to provide prescription renewals for her. And she was pretty upset that her family doctor wouldn't take them over. And as we moved along, it became a bit clearer to me why her family doctor might not be so keen on taking over the prescriptions for clonazepam, alprazolam, zopiclone, and risperidone. So, those are not tiny doses, and someone on 2 benzodiazepines always makes me a little bit just uncomfortable anyway. But it turned out that Dorothy was not taking just those medications in those doses. She had a number of things happen to her, including a viral illness that left her feeling really unwell and unsettled, then some other family challenges, and then finally COVID. And then the loss of her psychiatrist, which made her feel very anxious and created a situation where she was misusing her benzodiazepines. It wasn't entirely clear how she was dividing the clonazepam up, but she was essentially taking all the alprazolam at night, so 5 to 7 tablets, or averaging about 3 milligrams of alprazolam, along with the zopiclone and risperidone, because by the evening time, she was feeling really lousy. She had terrible buzzing in her head, and she described a situation where every morning she woke up feeling hungover, tired, could hardly get going. And as she moved through the day, she had all kinds of muscle aches and pains, feeling dyskinesia, foggy-headed, poor memory, and then increasing headache, buzzing in her head and ringing in her ears, which, needless to say, fit a benzodiazepine withdrawal syndrome. Not to say that she wouldn't also have an anxiety disorder or some other sort of organic things that could be part of her picture. But I was pretty convinced that benzodiazepine withdrawal was what was going on. And I think it's important to think about benzodiazepine equivalencies kind of in the way that we think about opioid equivalencies, by converting things into milligrams of morphine equivalents. I lean heavily on the Ashton manual. It seems amazing to me how few resources there really are about benzodiazepine management. And there's a little bit of discrepancy around what the absolute equivalencies are. But just to sort of put in your mind that 0.5 milligrams of alprazolam is about 10 milligrams of diazepam, or perhaps less. Again, there's always variation for people in terms of how they metabolize, how long they've been taking it, and tolerance. So for this patient, her 3 milligrams of alprazolam is equivalent to about 60 milligrams of diazepam there. And we need to really be careful, especially I think when people are talking about 0.5 milligrams of clonazepam, which sounds like such a low dose, and 2 milligram tablets or 2 milligram tablets of alprazolam seem to be frequently prescribed, that's not a small amount of diazepam overall. The other thing that this chart is intended to highlight is the half-life. And so you'll hear me talking about why we need to change to long-acting benzodiazepines to avoid the highs and lows of rapid onset and short-acting benzodiazepines. And the key thing about diazepam is that its metabolite is an active metabolite, and that's why it has such a long half-life. That's why we tend to use it so much in alcohol withdrawal, but why we don't use it in people who have severe hepatic dysfunction because of that active metabolite. So our challenge with benzodiazepines is not unlike people where we talk about doing opioid tapers, and that's so difficult. We need to try to really engage them in terms of why they might feel better if we can at least get a reasonable approach to their benzodiazepine prescriptions. It may not be a reasonable goal to taper everybody off their benzodiazepines. We may be looking at safer, lower doses of longer acting medications. We should consider prescription strategies like blister packs and adjusting dispensing intervals. And I think, again, like in opioid prescriptions of old, giving people a month's worth or more of benzodiazepines allows them to, go through them faster, use them up, run out, and get into all kinds of difficulties. So the challenges are really how to approach a taper. And the big deal is go slow. I found a number of references that talk about weeks to months, and I would say it's really months to many months, because if you move too quickly, needless to say, people experience not only withdrawal symptoms, but increased anxiety, which confirms for them that they have terrible anxiety that only responds to benzodiazepines and makes it harder to rationalize the treatment and get them onto medications that would be safe for long term. In general, the goal is to try to switch to one benzodiazepine and a longer acting benzodiazepine. And diazepam is talked about frequently in the literature, but there's actually not strong support for it being diazepam as opposed to a different medication. If someone was already on a longer acting benzodiazepine like clonazepam, you could use that. We want to switch them to scheduled doses, ideally TID moving towards BID. And I think the key thing is that sometimes we need to make the switch a little bit more gradually than we might have thought. So that can happen in two ways. For example, if someone is on 2 milligrams of alprazolam 3 times a day, you don't need to switch all 3 doses at once to a longer acting benzodiazepine. The other thing is that you don't need to switch the full 2 milligram dose completely over to diazepam. So you might choose to start with the bedtime dose, divide that between about 1 milligram of alprazolam and about 10 milligrams of diazepam, and see how they tolerate that. And that will really help. It's probably a bit of a dose decrease, as again, we would do with opioids, trying to think about reducing by 10 to 20% in equivalencies. But it helps us to not over-medicate, not hugely under-medicate, hopefully buy a little bit of goodwill in terms of the process. And then, of course, we'll have to look at how to manage insomnia, anxiety, and mood issues along the line. So essentially, that's what we did. It did not seem reasonable to me to add a third benzodiazepine to the mix of alprazolam and clonazepam. What I elected to do was to divide them up so that there was a good dose of benzodiazepines in the morning. Even though she wasn't feeling anxious or as though she was needing it, the goal was to have some longer acting benzodiazepine on board to try to avoid the peak of the increase in anxiety and withdrawal symptoms as the day went on, and then to gradually work our way down by 0.5 milligrams of alprazolam, which is about the same as 0.5 of clonazepam, in slow and steady stages, adding mirtazapine for sleep. Another option would be to increase the risperidone for sleep, and then trying to engage some other supports along the way. So that is very much work in progress, but an overview of how to manage someone who's on prescription benzodiazepines. It's obviously challenging in different ways when we're talking about people who are using street benzodiazepines. The most common that we hear about is Xanax bars, which in theory are 2 milligrams of alprazolam. But we really don't know what they are. They typically contain some alprazolam, some other benzodiazepines, and a lot of other things. And the other thing that we're hearing about these days is benzodiazepines or benzo analogs within the opioid street supply. So this kind of raises two questions. The first is, what should we be doing about people who are using opioids, whose opioids may be contaminated by benzodiazepines, and whether we should be co-prescribing benzodiazepines for that withdrawal syndrome. And I think my answer to that is a pretty clear no, for a couple of reasons. One is that we really don't know what people are being exposed to, and we could over-prescribe. What's in there is changing all of the time. The other is that I think the primary goal for people using opioids is to get them on opioid agonist therapy. And the hope being that as they reduce their opioid use, they will be reducing their exposure to benzodiazepines, and that gradual taper is going to help. So we didn't talk about the risk of seizures with sudden benzodiazepine withdrawal. Of course, that's something that we want to avoid. But with a gradual increase, and then hopefully being able to make some headway with opioids or using other things to manage anxiety, I think it's really important to stay away from prescribing benzodiazepines in this situation. The other question is what to do about people who are using benzodiazepines or benzos and other medications like stimulants as their primary substances. And the literature at this point, I don't think really supports prescribing benzodiazepines as harm reduction. I know there may be some different thoughts around that, and there are some specific considerations related to COVID around people who are requiring shelter, and we heard about that in the panel. So there may be specific considerations where prescribing benzodiazepines would be considered, and if so, those should be long-acting benzodiazepines, really considered on a case-by-case basis with very careful dispensing overall. So I'm going to pause. I know we don't have much time for questions, but if people want to make some comments or questions about benzodiazepines before we talk about opioids, I'm okay with that.
Issue will still avoid seizures and could be more easily titrated, especially important in street benzo users?
I guess for a couple of reasons, and I recognize that there may be some disagreement around that. I think the reason is that it's really hard to switch all at once and potentially unsafe because of really not knowing what benzodiazepines people are using or being exposed to. I think the overlapping withdrawal syndromes can definitely make it difficult. But if we can try to focus on opioid withdrawal symptoms and adjusting the opioid agonist therapy, I think it may make it a little bit clearer which kind of symptoms we want to manage. And then I guess the third and really important reason is that in general, I think our goal is to try to move people off maintenance benzodiazepines because of all of the risks that are associated with benzos, particularly in people who are using opioids. And I'll just draw your attention to this one slide that suggests that one of the strategies to be considered is taking people off methadone and putting them on buprenorphine in order to reduce the risks of the concurrent risks of benzodiazepines and methadone. And I think that while in theory that's an interesting strategy, I think it's hugely problematic because I think if you already have somebody on methadone trying to deal with a switch and withdrawal, two sets of withdrawal symptoms is really problematic overall. I'm going to pause there just because of the number of cases that I want to go through. I'm not surprised about questions, and if people wanted to contact me afterwards or continue these conversations on the chat, I'm really happy to. I apologize for opening a big can of worms that I can't completely answer right now.
I'll try to save the questions for you in case we come back to them afterwards.
Thanks, Katie. I see one, which is what do you do if you're a RAM seeing people over a short period of time? And I know that's something that's a real challenge. And I think what I would say to that is if you can develop an approach to a plan and share that back to primary care, I think that's really useful. And that's something that shouldn't be overlooked in terms of our role in RAM, educating primary care. One of the things that we've heard a lot, both from primary care and from emergency physicians, is that they don't often know what's actually happened to their patients. And there's a huge education opportunity here. And so you may not be able to manage this long, slow taper, but you can give guidance. You can mention the Ashton manual to providers in your quick consult notes back. They don't have to be lengthy, but that's really helping to sort of increase the scope of practice and in the community, which we need. So let's talk about Annie. She is a 25-year-old who came in having previously been on buprenorphine. She unfortunately was initially exposed to hydromorphone through her visits to the emergency department for gastroparesis, and at some point had started buying them and using them as a sort of workaround to having to go through the whole emerge process. So she did well after treatment on buprenorphine, and she tapered herself off. But through COVID, she was really unsettled by the isolation. She found that very difficult. She started using again, and wasn't using heroin or fentanyl, but was using whatever pharmaceutical tablets she could get her hands on, including alprazolam. So she came in to see us in RAM with her mother. And she had used just a few hours before the appointment, so she wasn't in withdrawal. She really wasn't sure what she wanted to do. She just knew that she didn't want to feel like this. She wanted to figure out a plan that was going to help her feel better. And she was pretty unsure about buprenorphine because she had to go through pretty intense withdrawal when she started it the first time. She was reluctant to do so, but when we really talked about methadone, it seemed too scary to her. And I didn't present sustained release oral morphine because I didn't feel that she had had good trials of what I would consider to be our two first-line treatments. So we talked about buprenorphine and what to do in terms of a start for her, and decided to do a home start. I know that we all sort of learned about starting buprenorphine with someone in withdrawal in the clinic and having them come in and observe them. And I'd like to think that we've all learned some other strategies along the way. So this is a handout that comes from the buprenorphine reference guide that's part of the opioids clinical primer. It draws very, very heavily on a patient handout developed by Lake Ridge Health, so with great thanks to them. And what I like about this is that instead of a SAWS, so a self-assessment opioid withdrawal scale, which I think is a little bit challenging for some people and hard to score, people can use this to identify 5 symptoms of withdrawal, and that equates to where they need to be on a SAWS, which I think is 17 or so in order to start. I would still advise them that if they're not feeling certain, that they wait and wait even a little bit longer. But when they're feeling moderately to severely rough and have not taken an opioid in at least 12 hours, then they could take their first dose of buprenorphine. And I would usually encourage them still to take 2 milligrams as a test dose rather than taking 4. Because it's better to not experience precipitated withdrawal and be turned off the whole process. And if they're not feeling worse, then they can go on to take another 4 milligrams and up to a maximum of 12 milligrams a day. So this comes along with a little log where people can record what they've taken, and they can use that to calculate what they took on day 1. Plan to take that as a full dose the first morning of day 2, with instructions for going up on day 2 or day 3 to a maximum of 20 milligrams. I think you need to be pretty certain that someone is going to, clearly understand those instructions, not decide that more is better and take it all at once on day 1. Ideally, have someone who can help to support them through that process. And so Annie actually did really well day 1, 2, 3, but then she missed her dose, didn't come back. And one of the, learning points from COVID is that if people don't come back for their in-person visit, we shouldn't consider that as meaning that they have been lost to treatment, right? Now that we're all practicing virtual care, whether by phone or video, a phone call is a perfect way to re-engage someone. So reaching out to her, we were able to get her restarted really quickly. And I'll breeze through just to say that she did really well. But a different situation is a guy like Brad, who was on methadone for a good number of years and did quite well on methadone with full carries for several years, but he didn't feel great. He never really liked methadone. He said that it didn't help his back pain. He had a lot of sweats, which weren't managed by other medications. He felt like he broke out. His skin wasn't good. And then a whole series of things happened. He ended up in jail, and then when he came out, was using heroin and came to see us looking pretty unwell with cellulitis from injecting fentanyl and a number of other things. So again, sort of the question about buprenorphine, methadone, or sustained release oral morphine for him. And I really thought that he might want to consider buprenorphine, since he had not liked methadone, even though he'd done well on it for some period of time. But he didn't feel that it was going to work for him, even when we talked about the fact that he didn't have to be in withdrawal to start. I wasn't quite ready or sure about SRAAM or Acadian at that point. We talked about methadone, but recognizing how much he was using and how hard it might be to get him to a therapeutic dose, I decided to co-start methadone and the morphine at the same time. And this is something that those of you who attended Mel and Lori's session in the morning might have heard about, strategies to try to help people get to doses that are actually going to make a dent in their withdrawal symptoms and cravings to help reduce their use sooner rather than later. So some of the guidelines that we've reviewed suggest starting doses up to 200 or even 300 milligrams of morphine a day. I didn't have that much confidence getting going in a first-person co-prescribing, and I still feel committed to 30 milligrams of methadone as the maximum dose, but I was at least prepared to start him on both. And so that was our starting dose, and we increased as rapidly as possible, according to guidelines, up to about 150 milligrams of methadone. However, at that dose, he still was not really making a great dent in his use, not meeting his goals, and not feeling well. And I was starting to get really antsy because we hadn't had an EKG done, and although he didn't have any obvious risk factors for prolonged QT, I wasn't feeling so comfortable. I had recently had someone who actually had a VTAC arrest, and so really trying to figure out what to do, and just holding the course wasn't working. So the turning point actually happened when he had a dental abscess. He had missed a dose, and we weren't going to be able to increase his methadone anyway. And I prescribed Acadian or SRAAM 50 milligrams as an intervention to try to help manage his pain and withdrawal symptoms. And he actually felt substantially better, and that led to our having a conversation about the role of SRAAM or Acadian for him in terms of his management. So most of my guidance around this has really come from the BC CSU guidelines, and they acknowledge that their approach is based on the protocols used in various studies. There is no real best approach at this point in time, except to say that we should be considering this more readily, I think, for people who are not really getting to where they should be, or who have risk factors with methadone. One of the things to remember about morphine is that its long duration of action is not because it's a long-acting medication, it's the pellets that it's in. And so it has lower risks than methadone in terms of people who that sort of buildup of the half-lives over time. We can assess people and really see whether they're sedated, almost regardless of where they are in terms of their dosing overall. And at least in the general small number of studies and the meta-analyses that have been done of those, SRAAM is at least equal to methadone. It's non-inferior, and the subjective reports of people taking it are more positive. It appears to be preferred because it helps with cravings, and there's less sedation, and people tend to feel well over time. So it's preferred by a majority of people. Having said that, the doses can be a little bit scary. So in the Beck study, up to almost 800 milligrams is an average dose, and in the Hammock study, up to 1,200 milligrams overall. The BC guidelines suggest that you start assuming sort of an equivalency of 1 to 4, meaning 10 milligrams of methadone would be about 40 milligrams of morphine. And it actually looks as though the recommendation is that you take someone's dose of methadone, just convert it into morphine, and then increase gradually from there. And I just want to say, to be clear, morphine, specifically the RAAM formulation, that's the one that's studied in terms of OAT, not Contins or anything else. The other thing, again, it's noted there, is that it's the pellets that are inside that we want people to be taking, and the instructions are fairly clear about opening those pellets and sprinkling them on applesauce or in a cup, followed by drinking water to make sure that people aren't taking out very, very large doses of morphine potentially and having other things happen to them. So I wasn't really ready to take 150 milligrams of methadone and turn that into a prescription of 600 milligrams of morphine and send this patient on his way to be followed up in a couple of days. What I chose to do was to decrease the methadone by an amount and increase the morphine by an approximately equivalent amount. So recognizing that the methadone still wasn't fully effective for withdrawal symptoms, decreasing by 20 milligrams of methadone, if you think that that's about 80 milligrams of morphine, I increased him by 100 milligrams, and we continue to do that week by week. Until at 500 milligrams of morphine, we discontinued the methadone. He was feeling pretty good. He missed a couple of doses, and one of the things about morphine is that if someone misses 2 doses, you need to decrease the dose by 40%, or you should, according to those guidelines, and use clinical judgment. And at the moment, he's at 350 milligrams, doing really well, has reduced his use a lot. So I'll pause there, and Katie, you can let me know if there are some questions that I can address.
Sorry, I don't know if you heard that one.
No, I'm sorry.
Okay, sorry. Is there a recognized morphine equivalent for methadone?
So as I mentioned, and this comes from the BCCSU guidelines, the guidelines suggests that most people net out with an equivalent about 1 to 8. I think the average that they found in terms of people converting was at 7.7 or something like that. So the recommendation is to start with considering an equivalency around 1 to 4, but then increase accordingly based on someone's symptoms.
Perfect. How do you deal with carries, or is Cadian always observed dosing? I use it in pain patients at home, but am reluctant in OUD patients. Have one guy on 1,500 milligrams, weaning slowly back to methadone, now 110 methadone and 800 Cadian.
That's a pretty big dose. If 110 milligrams of methadone is 400, 600, yeah. So I don't know that there's a perfect answer to that. I think that, again, looking at the guidelines, they suggest that people on Cadian be on daily observed dosing for a prolonged period of time, typically longer than what we do with methadone, which I know already feels kind of onerous to many people. But it's because of the risk, I guess, of all of those milligrams of morphine in tablets and what could happen to them if they were misused or diverted. So I think that people could work their way towards take-home doses if they were really stable, and that would indicate, you know, all of the things that we use to assess stability in terms of clinical stability, probably including urine drug screens, even though there's a lot of discussion, and I'm sure we'll have more about the role of urine drug screens, and then starting slow and going slow with, you know, 1 a week and not consecutive days perhaps, and just having a sort of careful threshold for that.
Great. One last quick one is, where do you find the self-start document?
The home start document that I shared is in something called the buprenorphine reference guide. That's part of the opioids clinical primer. I think it's all over our lobby web page. If you Google Mac Health, you'll see it there. If you email me, I'm happy to share it. It will be updated over the next few months as we look at some of the changes around incorporating changes around microdosing and some other resources. But that's where you can find those handouts for now.
Great. And you have about 10 minutes left. Sorry.
Okay. For alcohol, the number one substance on people's minds. So we'll start by talking about Joe. And I think part of the reason that I chose Joe is, again, the fact that we don't always have a clear cut. The issue is alcohol, right, with nothing else, and this is how we're going to manage it. So I was seeing Joe for opioid use disorder. He was on buprenorphine. And he came in looking really unwell, flushed and shaky and sweaty. And he hadn't missed any of his buprenorphine doses. He hadn't been using other opioids. We didn't really know what was going on. He had been complaining of nausea and vomiting in the mornings for quite a while. And I had really missed all of the clues that this was alcohol withdrawal. When his sample was benzodiazepine positive again, and I asked him, like, what were these benzos about? He had an admission to hospital and been given a whole bottle of diazepam to treat alcohol withdrawal. So he kept sort of dosing himself here and there when the withdrawal got really bad. So this was an opportunity to really think about the overlap of opioid use disorder and alcohol and how to approach that. So he had tried to stop himself a number of times, but just would get to day 3 or 4, feel pretty lousy and end up restarting again. So I think the main sort of takeaway from this slide is, who doesn't need withdrawal management? And that would be people who don't drink daily and have not previously required medications to treat withdrawal. Otherwise, all of these people who are, drinking pretty regularly and have been to an emerge for withdrawal, et cetera, obviously do. So the question is, where? And in general, because of the limited number of beds for medical withdrawal, and especially during COVID with all of the limitations, the question is, where can we assist people to withdraw? So again, back to the BCCSU, they really recommend the PAUSE scale as a way to help determine whether people should be admitted for medical management or not. And a score over 4 suggests that someone is at risk for complicated withdrawal and should be considered for admission. And I think the challenge with this scale and using it regularly is that are a couple of things. First of all, it was developed for patients for medically ill inpatients, most of whom would already be in withdrawal. So that doesn't represent the people who are coming into our office necessarily who aren't in withdrawal at the time. It also suggests a blood alcohol level. You could use a proxy question for that in terms of how recently someone had something to drink. And it also suggests assessment of blood pressure and heart rate, so autonomic symptoms. And those autonomic symptoms are really helpful in terms of increasing the sensitivity of the test, but they're not practical, especially if we're trying to do virtual assessments these days. So while I think it's a very useful tool to know about, I think that this represents a sort of easier or cleaner set of questions that we could use. We could even use if we're assessing someone over the phone in terms of making a determination about whether they're suitable for a day detox or withdrawal management. And this comes from the documents that are on the Medify website that were posted as part of the COVID responses overall. So I think, big obvious ones there, someone who's on methadone, or people who are on high dose benzodiazepines, probably we don't want to do a day detox, whether it's in our clinic or at home, because of the risks of needing high dose benzodiazepines and overlapping benzodiazepines with opioids overall. So I'm going to talk about the 2 different scenarios, whether we're going to bring someone into clinic or do withdrawal management at home. And I think the key things, if you're bringing someone into clinic and you have that opportunity, is that we still use a symptom-driven protocol if we can see someone. So we can use a CWA in the office if we're lucky enough to be able to allocate a room somewhere. And we should tell someone to come in around, so that we're seeing them around the time that they would be starting to experience withdrawal. We don't ideally want them drinking, in the morning that they're coming, unless their withdrawal starts so quickly that they would be moving into withdrawal at 4 to 6 hours. And of course, we need to have a threshold for when to send people to the emergency department if they're really not responding well. So if they're worsening rather than improving with our doses of diazepam. I think in a day setting, we still don't have a lot of additional supports in terms of managing them. So you'd have to think about what your upper level of comfort is in terms of diazepam, maybe 60 or not more than 80 milligrams. And I think one of the things that those of us doing this have learned is that even though in theory at the end of a day or 24 hours, someone is benzo loaded and should be okay, they don't feel like that. They still go home feeling as though by day 2, 3, they're needing some more benzodiazepines. But decreasing doses and a time-limited prescription is really key so that you don't end up with someone who now has a benzodiazepine issue from repeated prescriptions. For someone who does not sort of meet high risk and has someone who could help them, I think medication to be taken at home, if there's a friend or family member who can support them, is really feasible. This could be done in a shelter as well. And again, I know there are some protocols. Again, BCCSU put out their document on, I think, risk mitigation in the context of a dual pandemic. There are some guidelines that Suzanne Turner and the St. Mike's group put out, and there may be others. I apologize if I'm missing you. In this situation, I think fixed dosing is much more feasible. And again, reminders that anyone we're offering withdrawal management to benefits from follow-up medications, not naltrexone if they're on buprenorphine, obviously. But what about people for whom benzodiazepines are not so appropriate? Either, again, because they're on opioids, we're not sure whether they're going to continue drinking or not. I know there's been a lot on the listserv about gabapentin and different approaches to protocols, and we've been using it increasingly. And I think one of the things that's really important about it is that it can be started while someone is still drinking and titrated up, and the hope is that as that dose is increasing, their alcohol is decreasing. But at least when given at therapeutic doses, it doesn't appear to cause significant impairment. For someone who's had a history of withdrawal seizures, it's not sufficient. But for those who haven't had and are not benzodiazepine dependent in that way, I think there's a great role for it. So some of the guidelines, these again come from, are cited in a number of places, and you can find the table in the BCCSU guidelines. They suggest fixed dosing plus some extra PRN doses overall, up to a maximum of 1,800 milligrams in the first 24 hours, and then going up to 3,000 or even 3,600 at most. Those start to feel like pretty big doses over time. And so you would want to think about someone's risk for sedation, how likely they were to be drinking or not drinking at the same time, and what other medications they're taking. And then they suggest tapering by 600 milligrams per day over 3 to 5 days. I guess one of the things I want to suggest is that we might not want to taper someone off completely, because gabapentin has evidence as an anti-craving medication, and because of those subacute withdrawals which last for a long time. It might be something that we want to continue for longer. So with Joe, he just was not in a setup where he had someone who could really support him, and I wasn't so comfortable prescribing more benzodiazepines on top of the benzodiazepines he had stashed at home. And so we decided that what we should be doing, I apologize, is using gabapentin. I was a little bit leery about using high doses with him because of his buprenorphine, although his buprenorphine wasn't at high dose and he wasn't on any other medications. And as I'm sure many of you have found, the sort of discussion around whether someone can actually sort of taper down and decrease or control their drinking while you're using medications, is challenging. People, if they can stop and have a period of not drinking, I think that's preferable if it's realistic. So really important, again, to then look at if he's still feeling unwell, what's alcohol withdrawal, what's benzodiazepine withdrawal, and what needs to be addressed potentially in terms of buprenorphine and addressing opioid use disorder. So I'll skip Connie, who's a much more straightforward home benzodiazepine protocol, to wrap up and say, with apologies for trying to cover so much so quickly, that in RAAM, we can't always fix everything all at once, but if we can try to identify a place to start, typically with the most problematic substance use, the highest risk, and begin an intervention that we can then work with, following them for whatever our capacity is, thinking about what the other resources are that we can sort of bring in or refer back to, then hopefully we can at least begin to make a dent, support each other and our patients, and build primary care capacity. Katie.
Wonderful job. So there's a bunch of questions, as I'm sure you predicted. I'll just start at the top. What do you do with patients with a PAWS greater than 4 who absolutely refuse withdrawal management, WMS not available, but have run out of money for alcohol?
I'd call Michelle Clayman at St. Mike's and ask her about how they managed sort of a managed alcohol situation. I don't have a great answer for that question, to be honest. I don't know that there's an easy way around that. I think if we can stay away from prescribing benzodiazepines and use the other tools within our armamentarium of gabapentin, pregabalin, hoping that people will at least sort of contain their drinking and not put themselves at greater risk. I would, of course, look at the other things that might be driving drinking around anxiety and mood disorders, and then all of the things that we don't have time to talk about today, but the social determinants that might help someone really stabilize and how they might be assisted there.
Perfect. So I'll save the questions because you're needed elsewhere, and I believe we're fully out of time, but thank you so much. And I know for me anyways, that chat was very helpful. So we'll email questions afterwards.
Katie, I'm gonna save the chat and send it to you.
Perfect. Thank you.
Sure. Send it on. I'm sorry for cramming so much in and happy to keep the conversation going around questions.
Okay, you can close it.
In a little break. Thanks, everybody.
Thank you so much.
Thanks.
Bye, Katie. Thank you.